be you.
Hearing will come to order. I didn't mean to scare you there. We're ready to get started now. Thank the witnesses for coming. I'll open it with a brief comment and then turn it over to my partner here, Mr. Van Halen. Welcome to today's hearing, focused on our critical health and retirement security program, specifically Medicare and Social Security. Today we welcome Rick Foster, Chief Actuary at the Centers for Medicare and Medicaid Services. Rick remains among the nation's foremost experts on healthcare policy, and we remain grateful for his nonpartisan analysis and for his returning to testify before this committee. It's good to see you again, Rick. We're also very fortunate to be joined by Stephen Goss, Chief Actuary for the Social Security Administration. Like Rick, Steve's analysis provides policymakers with an indispensable guide to the structural need for reforms. Steve, I've known you a long, long time. It's great to have you back. We appreciate your taking time out of your day to come and testify today. The failure of Washington to be honest about Medicare and Social Security and the federal budget threatens the economic security of Americans. For too long, policymakers have avoided the critical question on how the social insurance strategies of the 20th century can deliver on their promise of the 21st century. It's just that simple. The House Budget Committee has devoted considerable energy to changing Washington's culture of irresponsibility. The American people deserve better than empty promises with respect to these important programs. Earlier this year, we proposed, debated, and advanced a plan that helps fulfill the mission of health and retirement security for all Americans. Our budget charts a path to lift the crushing burden of debt, to spur economic growth and job creation, and to fix these problems. It's been a source of urgently needed debate, along with an occasional distortion or two. Both sides have engaged in the unfortunate weaponization of entitlement politics. It's bad for our political discourse, it hinders efforts at bipartisan solutions, and most importantly, it actually threatens the health and well-being of society's most vulnerable, who rely most importantly on these programs. We need a clean break from the politics of the past, and that begins with a shared consensus on the facts. So today's hearing is an effort to unpack the fiscal facts on Medicare and Social Security, two critical programs that represent a solemn commitment to America's seniors. This is a commitment that cannot be kept unless reforms are made. To help us get our arms around the magnitude of these two programs' financial help, I can think of no better witnesses than the ones we have today. It is just this simple. These are the most important programs of the federal government, right here, these two. Millions of people rely on them. They're going bankrupt. They have to be reformed in order to be saved. And it is crystal clear to anybody who looks at these numbers that the sooner we act to shore these programs up, the better off everybody's going to be. The less disruption that occurs in the lives of the people who rely on them the most. You can't help but turn on the TV and see what's happening in Italy, in Greece, in Portugal, you name it. A debt crisis is on our horizon. And a debt crisis is driven in large part because of these programs. So it's so much better for us as leaders to act like leaders and to fix this problem and do it under our own terms and our own timeline before it gets out of our control. And it's just that simple. And so hopefully we can begin a conversation with a recitation of the fiscal facts as the nonpartisan trustees and actuaries display them. And with that, I'd like to turn over to my colleague, Mr. Van Halen.
Thank you, Mr. Chairman. I want to join the chairman in welcoming our witnesses today, and I look forward to your testimony on what is a very important subject. I would note, Mr. Chairman, that this will be, I believe, the fourth hearing devoted to either Medicare or Social Security solvency, including yesterday's hearing where we had an extensive discussion of this issue with Secretary Sebelius and other witnesses, and I think that's entirely appropriate. But I want to note that we have not yet had a single hearing devoted to the issue of tax expenditures and revenue. And we all know that the President's bipartisan fiscal commission, on which you serve, Mr. Chairman, said that you can look at the tax expenditures in the tax code and find about $1 trillion every year.
We're working on scheduling that hearing.
Okay, well, but okay, we've had 4 on this issue, and again, we should have many more on this issue, but we have not yet had one on a hugely important part of our budget. There's no doubt that we need to make reforms in Medicare and Social Security to ensure the long-term strength and viability of those programs. We have very different views on how to do it. But, Mr. Chairman, if we're talking about the facts, let's also be clear about this point. The Congressional Budget Office analysis shows that the primary recent policy decision driving the need to raise the debt ceiling was the decisions in 2001 and 2003 to provide tax breaks that disproportionately benefited the very wealthy. That is what's driving the current debt ceiling. We're talking about bills, past bills due, and our ability to pay for those past bill dues. And as we all know, we have a very important conversation going on as to whether and how we take a balanced approach to that decision, one that includes important and difficult cuts in discretionary spending, one that looks at mandatory programs, one that looks at some of the things we can do to strengthen Medicare. We have different views on how to do that. But one what we would urge also includes closing corporate tax loopholes and dealing with tax preferences for the folks at the very top. So again, I'm glad we're having what by our count is the fourth hearing on this subject, but if we're going to take a balanced approach to the long-term challenges, let's include that conversation about tax expenditures. Now, with respect to Medicare and Social Security, again, we heard a lot of testimony yesterday from Secretary Sebelius and others. We believe we have to make very important reforms to Medicare. We believe we have to change the incentive structure so that we reward value of care and quality of care over volume of care and quantity of care. And Secretary Sebelius talked about some important initiatives she's taking with respect to improved coordination of care for dual eligibles, people on Medicare and Medicaid, people with a lot of chronic diseases where we spend a whole lot on the Medicare program. We need to look at those sorts of things. We are open to other ideas. What we're not open to is transferring all those costs simply to seniors on Medicare without dealing with the underlying costs driving the entire health care system, not just Medicare, but the entire health care system, of which Medicare is a very important part. And so, yes, we do object to the approach that was taken in the Republican budget, which the CBO says will not decrease health care costs nationally, but actually increase total health care costs and push a lot bigger part of that burden onto Medicare beneficiaries. With respect to Social Security, we believe that reforms need to be made to make sure that we strengthen the solvency of Social Security beyond the year 2036, 2037. We all know that if we do nothing to act now, Social Security beneficiaries would get 78 cents approximately on the dollar, 75 to 78 cents. Yes, we need to act sooner rather than later to address those issues. Again, we have differences of opinion on how best to do that, but no difference on the fact that we need to make sure we strengthen those programs. So we're in fundamental agreement that Medicare and Social Security require some reforms to be strengthened. We are in very big disagreement as to how to do it, and apparently we continue to be in a big disagreement over taking a balanced approach to the overall budget that says let's not make the kind of mistakes that we made that are actually driving the budget deficits at the particular moment. Let's deal with tax expenditures. Let's close some of those corporate loopholes, whether it's for the jets or for oil and gas companies. Let's look at the tax preferences for folks at the very high income end of the income scale on tax rates. So, Mr. Chairman, I'd like to have a lot more hearings on this particular issue, but I'd like us also to address the very important issue of tax expenditures as part of an overall budget discussion.
Okay, the gentleman made his point very clearly. Why don't we begin? Why don't we start with you, Steve, and then go to Rick? The floor is yours. Please turn your mic on.
There we go. Okay. Chairman Ryan, Ranking Member Van Hollen, members of the committee, thank you very much for the opportunity to discuss with you today the fiscal status of these programs. The 2011 annual reports issued by the Board of Trustees on May 13 have clearly laid out the projected future cost and financing of these programs under current law and our best assessment of future economic and demographic conditions. We are at the beginning of a substantial and permanent shift in the age distribution of our population. The drop in birth rates from the long-time average level of 3 children per woman through 1965 to just 2 children per woman since 1975 is in fact responsible. By 2040, there will be only 2 workers for every Social Security beneficiary, down from 3 workers per beneficiary throughout the period 1975 to 2008. As a result, the cost of Social Security will shift from 4.3% of GDP in the period 1975 through 2008 to a stable level of 6% of GDP for 2040 and later. Scheduled tax revenue will remain at about 4.5% of GDP in the future. Program sustainability for Social Security, therefore, will depend on making a choice to either increase revenue by 33% after 2035, reduce benefits by 25% after 2035, or some combination of these 2 changes. In the absence of legislation, the combined Social Security, OESI, and DI trust funds are projected to become exhausted in 2036 in our latest reports, with only about 75% of presently scheduled benefits being payable thereafter through 2085. It's actually 77% right away in 2036. Projected trust fund exhaustion is now 1 year earlier than in the 2010 report, largely because of lower mortality and net immigration and a slightly slower expected economic recovery since the prior report. Social Security total income, however, will continue to exceed expenditures, causing the trust fund assets to grow until 2023. But Social Security non-interest income is now expected to be permanently below cost starting 2010. This is 5 years earlier than expected a year ago. Positive net cash flow that had been projected at less than $10 billion for each year 2012 through 2014 in the 2010 Trustees Report has been replaced with projected negative cash flow of less than $20 billion for each of these years in the current report, largely because of the economic recession having a slower recovery in our assumptions. While GDP grew 0.4% less in 2010 than expected a year ago, the average real earnings level of workers grew by 3.1% less for 2010. Social Security and other trust fund programs are subject to special constraints that do not exist for other federal programs. The trust funds have no borrowing authority in and of themselves, so these programs must always maintain a positive cumulative net cash flow, a positive asset level. If trust fund assets were ever to become exhausted, payable benefits would be limited to the continuing revenue of the program. In the case of Social Security, only about 75% of scheduled benefits would be payable after 2035. Congress has always taken action in the past in order to prevent the precipitous drop in benefits that would be required if there were ever the exhaustion of a trust fund. Budget scoring convention presumes that Social Security shortfalls after any trust fund exhaustion that might occur would be made up with revenue from the general fund of the Treasury, requiring extensive borrowing from the public. In fact, the law would not permit this. If currently scheduled benefits are to be paid after 2035 for Social Security, the Congress will need to pass legislation providing more revenue. Graphs of the theoretical growth in the publicly held debt after trust fund exhaustion, based on the presumption that full benefits would continue with additional revenue from the general fund of the Treasury, may be impressive. However, the reality of the precipitous drop in benefits at trust fund exhaustion has actually proven historically to be a more certain motivation for congressional action. The total federal debt subject to ceiling includes the amounts the Treasury has borrowed from and owes both directly to the public and indirectly to the public through the trust funds. In the absence of asset accumulation by the trust funds in the past, the Treasury would simply have needed to have borrowed that much more directly from the public. The total debt subject to ceiling, therefore, depends entirely on the net cash flows of all the federal programs that do not have trust funds. Changes in Social Security income and spending do not and will not have a direct effect on the total debt subject to ceiling, but they certainly do on the publicly held debt. Again, thank you for the opportunity to come and talk to you today, and I'll be happy to answer any questions.
Good morning, Chairman Ryan, Representative Van Hollen, and distinguished committee members. Thank you all for inviting me to testify today about the financial outlook for the Medicare program. I'm accompanied by Claire McFarland, sitting behind me, who is the Deputy Director for Medicare and Medicaid. Sure. Claire McFarland, who is the Deputy Director for Medicare and Medicaid cost estimates in the Office of the Actuary. Now, as you know, healthcare cost growth generally exceeds that for the economy at large. This happens because healthcare costs grow in proportion to the number of people who are covered, the general inflation in the economy, in addition, excess medical specific inflation above and beyond general, as well as increases in the volume and the intensity or the average complexity of services that are provided. In contrast, the gross domestic product increases with the number of workers, with general inflation again, and also with roughly with productivity gains in the economy. Now, over the last 10 or 20 years, per capita healthcare cost growth has run about 1 to 2% faster than growth in the per capita GDP. If we look at Medicare specifically, over the last 10 years, the average annual increase in costs for Parts A and B combined of Medicare has been 7.6%. And that's a little less than 2% of that is due to growth in enrollment, in other words, the number of beneficiaries. That's a lot faster than the economy grew. Over the next 10 years, however, we expect a much slower growth rate than we've seen in the last 10 years, in part because come January 1st, 2012, under current law, we have to reduce payments to physicians by almost 30%. In addition, there are the Affordable Care Act savings provisions, notably the productivity adjustments to payment rate updates for most other kinds of healthcare providers, as well as the reductions in the Medicare Advantage payment benchmarks. Together, these factors result in a slower rate of projected growth for combined A and B costs to about 5.3% on average over the next 10 years, and 3 percentage points of that is just in growth in enrollment as the baby boom retires. In the longer range under current law, we now have Medicare costs in total that represent about 3.6% of GDP, and that's projected under current law to be about 6.2% at the end of the trustees' long-range 75-year projection period. Now, that's far lower than the level that was projected prior to the Affordable Care Act. On the other hand, it's still a 70% relative increase compared to today. So if the current law payment provisions for Medicare are sustainable in the long run, then we're looking at a substantial improvement in the financial outlook for Medicare. But there's a lot of evidence that suggests some of these payment provisions will not, in fact, be sustainable in the long range. For example, Congress has overridden the physician payment reductions required in every year in 2003 through 2011. And I'll guess that you'll be likely to continue doing that for some time to come. Also, as I testified before your committee in January, the productivity adjustments under the Affordable Care Act could well lead to a situation where Medicare payment rates are just inadequate, so that they may not be viable in the long range. If, in fact, these features do not prove to be viable, then the actual cost for Medicare will be much higher than projected under current law. We have an alternative to current law, an illustrative alternative that the Board of Trustees asked us to prepare to illustrate the extent to which costs could be understated under current law. Under this illustrative alternative, costs are projected in the long run to grow from their current level of about 3.6% of GDP to 10.7% by the end of the period. So that's about 3 times the current level. So, in conclusion, the current law Medicare projections do serve as a valuable indicator of the potential improvement in the financial outlook that could be achieved if the growth rates in healthcare costs can be slowed down, as current law attempts to do. Moreover, the Affordable Care Act puts in place a very aggressive program of research and development to help find innovations in the delivery of healthcare and how we pay for healthcare through bundling of payments, through more integrated care, all with the goal of improving the quality of care and the cost effectiveness of care. This is a great opportunity to design and test and implement meaningful, long-lasting reforms. They offer the potential for lower cost levels without question, and some potential for lower growth rates. Now, until these are tested, however, we can't really have a good sense for what will actually happen, but research is a good idea. I hope this information has been helpful to you all, and I look forward to continuing to work with all of you as you struggle with the financial challenges for beneficiaries and the budget from the Medicare program. Thank you.
Thank you. You know, Mr. Foster, when was the first year you did your appendix to the trustees report? Was last year the first year?
I've been doing the appendices with my actuarial opinion statement since 1995 when I became chief actuary. The last 2 years, they've had some extra language in them,
Right.
cautioning about the possible non-sustainability of current law provisions.
The way I read your appendix, at least the last 2 years, and please correct me if I'm wrong, it reads kind of like the way CBO describes their alternative fiscal scenario. CBO basically says that they think the alternative fiscal scenario is what is sort of more reality-based. What they think based on patterns in Congress, you know, the SGR getting patched and things like this, that's the more likely outcome of policy, and therefore they're projecting based on that. Is that what you're attempting to do essentially with your appendix?
That's what we do with the illustrative alternative projection, where we essentially assume what is perhaps a more sustainable approach for these provisions. In my appendix, in the certification statement, I have to certify that the projections are reasonable, based on reasonable assumptions and methods. I say that they are for current law, but then I caution that current law may not be sustainable.
Right.
And point people towards the illustrative alternative to current law.
What's the 75-year unfunded liability under your alternative? You call it your alternative illustration?
Yes. The way you define it for budget purposes is not the same way we define it for trust fund solvency.
Right.
But using your definition, where you take the difference between hospital insurance income and expenditures in the long term, this is a long-range 75-year present value, and then you add to that the present value of the general revenues that are provided in current law to pay for parts B and D, but for which there's no dedicated revenue source. If you take that definition, then the answer is $37 trillion as a present value over 75 years.
What was that number last year in your appendix?
Similar, perhaps a little bit lower. I don't have it handy.
Okay. Could you bring up chart 1? So I see your chart number 4, which is your, in your testimony, we have basically that chart, we just put it in color. Chart 4 and chart 7 in your testimony. Chart 1 here, which is chart 4 in your testimony, is the Medicare hospital reimbursement rates. And you're showing us that Medicare and Medicaid hospital reimbursement rates are going from about 80% today down to 60% in 2020 and down to 33% at the end of the budget window. Can you show us chart 2, please? And then you're showing us physician payments are going down from 60% today to 33%. Medicare below Medicaid starting in a few years. Is this sustainable? I guess that sort of is the reason why you have this appendix. If Medicare is going to be paying providers at rates by which for every senior citizen walking in their door, walking to the hospital or the doctor's office, they lose money on each person, are they going to keep providing the benefit? And have you made calculations as to what that's going to do to the Medicare provider community with respect to whether they have negative margins, meaning bankruptcy or not, and what are those projections, you know, as you carry these numbers out?
Yes, you had several questions in there.
Yes, feel free to take your time.
First, regarding these comparisons, we assume that private health insurance payment rates to their doctors and their hospitals and so forth would continue to be negotiated in an open market pretty much the way they are now. And then we compare the Medicare rates, payment rates, to those for private health insurance. Because of the productivity adjustments and some other reductions in growth rates within the Affordable Care Act, for all the Part A providers, you get the pattern that you showed in the prior slide, and the figures you quoted were correct. And that assumes that, again, the private health insurance can't do something comparable to these mandated reductions in growth rates that are part of current law now for Medicare. In looking at those, it's pretty hard to imagine that they could be sustainable. Because when you think about it, the providers have to pay certain input cost increases. They have to pay their workers somewhat more next year than they do this year. They have to pay higher energy costs. They have medical supplies. They have rent or leases that go up. And they don't get a break from the energy company just because Medicare is paying them a lower payment update. They still have to pay all these input costs. So what we're paying them in the future is the growth in their input price, minus about 1.1%, representing the productivity gain in the economy overall. And that accumulates, as we've seen in these charts, to quite a bit of a difference. And that's why I've tried to raise concern about this and make sure that all of you are aware and you can monitor this and make sure that nothing bad happens. Because as you pointed out, Mr. Chairman, if at some point our payment rates to providers become less or significantly less than their cost of providing services, they either will be unwilling or unable to continue providing services. Now, before that happened, I think you all would have to act to override the productivity adjustments, much as you've had to do for the sustainable growth rate formula for physician payments. So I think that's the more likely scenario, but absent that, there could be very serious
What would
access
your
problems.
projection be on the amount of providers unwilling or unable as time goes on, say 2030, 2050, as we go through this chart?
Well, we estimated, we did a simulation for hospitals, skilled nursing facilities, and home health agencies, looking at their actual cost report data and calculating that if everything else stays the same, just what would the impact of these slower provider payment updates have on their margins over time. And I'll confess I've forgotten the specific figures, but they're in our April 22nd memo that showed over, even within 10 years, a significant proportion of these providers would go from positive margins to negative margins solely as a result of these slower payment updates. And in the longer term, in the trustees report, it gets up to be over 40% of these providers would end up shifting to negative profit margins.
40%?
Yes, sir.
Premium support's an idea that's been around for years. You've looked at lots of different plans. There's the 1999 Bro-Thomas, there's Rivlin Domenici, there's the Rivlin Ryan, there's what we put in the House budget. I don't want to get into specifics of each plan because they all approach premium support in a slightly different way. And the design features of premium support are clearly something that's worth debating and negotiating and all of the rest. But each of these ideas share an underlying principle, and that is that a system requiring providers to compete against each other for patients' business, with more assistance for the poor and the sick and less for the wealthy, can responsibly reform Medicare without compromising its role as a vital safety net program. I want to get your basic framework thoughts on this. Do you think a system set up along these kinds of design features can achieve savings in Medicare while continuing to provide for a basic Medicare benefit?
As a general rule, certainly. These kinds of premium support approaches have been discussed many times over many years. There have been different designs. Most of the premium support proposals have used an approach not unlike Medicare Advantage, where there's a payment benchmark that plans are tested against. And if a plan can come through with more efficiency and a lower cost than that benchmark, then participants in that plan would get a cheaper premium. And the plan would benefit and Medicare would benefit from the lower cost. On the other hand, if a plan's less efficient and has a cost above the benchmark, then the beneficiary would have to pay most of that extra difference, or all of it. And those plans would be less attractive. So we've estimated for many years that the competition among plans in a premium support setting like this could have advantages and lead to somewhat lower cost for Medicare. It can get you to the lowest cost consistent with good quality of care. It may or may not help a lot with the cost growth. In other words, you might go from a starting point here down to a lower level because of the competition, but they both might grow at a similar level. It's much harder to attack the growth rates. If you build into a plan like this a different approach for paying the support, which has an index built in that is typically lower than the expected premium growth or the cost of health care, then you can address the cost growth issue, but then you get into all the issues of do the premium support payments remain adequate over time?
Right. So the secret then is, which has been vexing all of us from both sides of the aisle, how do you get at the root cause of health inflation? So we shouldn't, what I'm getting from you is we shouldn't delude ourselves that Medicare reform fixes everything in health care. It can help fix Medicare problems, but unless you address the underlying root cause of health inflation, you really can't fix these problems at the end of the day. Is that not the case?
Yes, I would agree with that. If you look at the causes, the underlying causes of healthcare cost growth, income is a big part of it. The richer we are, the better healthcare we want and the better healthcare we can afford. That problem kind of takes care of itself because if the costs are going up comparable to our incomes, then the overall cost is similar to growth in the GDP and nothing gets harder to handle. But often, of course, it goes up faster than that. Another of the major factors driving healthcare costs is technology. We all want the best possible medical care, and the research and development community is more than willing to invent new techniques and treatments and drugs and so forth, and often they're pretty expensive.
And under a fee-for-service model, that sets the incentive structure for them just to keep billing and keep building and keep adding to the costs because they just get reimbursed on a fee-for-service schedule. Would you agree that perhaps a better line incentive structure where the provider community on technology has a research and development incentive to provide better costs, cheaper devices that have more value? Do you believe that under the right incentive structure, you could put in place sort of a virtuous cycle, productivity improvement and innovation, working to bend the cost curve versus the status quo that as we now know it today?
Yes, I think it's possible. To date, there's been very little incentive to focus on cost-reducing technology. Most of it's been cost-increasing, with some notable exceptions. To the extent that you send a signal to this research and development sector that things have changed, we can no longer afford to pay for every new thing that comes along, even if it's only marginally an improvement but costs 10 times as much. If we can't afford to do that anymore, hopefully they'll get the message and turn their considerable abilities to cost-reducing techniques. So premium support can be consistent with that approach. Traditional fee-for-service is typically not.
Yeah. I want to get
Mr.
to
Chairman, I have a question.
when you have your time.
You have time, would you yield?
No, because I don't want to take up
Thank
any
you,
more
Mr.
time.
Chairman.
You're welcome. Mr. Goss, a quick one. Some have argued that because Social Security is able to pay full benefits until 2036, action now is not necessary. You hear this more and more these days, which is there's no problem, don't have to worry about it, not till 2036. I think we know what happens then if nothing is done, but give us a sense of the cost of delaying and the sense of how gradual reforms would be if we do it now versus how severe they would be if we delay. And what is the growth in the unfunded liability on average on a year-to-year basis? How much deeper of a hole are we digging ourselves every year we delay fixing this problem? Because it's a pay-as-you-go system, 10,000 boomers retiring every day with far fewer workers following them into the workforce. It's the same problem with Medicare. What kind of hole are we digging ourselves every year we don't do anything? And how gradual versus how severe are we looking at based on when we decide to do something?
Thank you. Excellent question. And I think it's really the same for Medicare as it is for us. Our unfunded obligation that we project over the next 75 years, which is for the shortfalls in the years 2036 through 2085, is about $6.5 trillion in present value as of 2011. In fact, if we waited 5 years to enact changes from now, the present value of that shortfall as of 2011 would still be $6.5 trillion. The shortfall is what it is over the period. Indeed, the real advantage of enacting something soon, and I would emphasize enacting something soon as opposed to acting per se, is that it really gives people advance warning, allows you many more options to consider, and allows you the ability to phase things in more gradually over time. It is possible that we could just simply follow present law, wait till 2036, do nothing, and allow benefits to drop by 23% precipitously for everybody receiving benefits and Social Security. If we really did nothing, in 2018, very, very much sooner, our disability insurance trust fund will become exhausted, and we would have a 14% reduction in benefits.
In 2018?
In 2018, that is the date where we are projecting
14%?
a 14% reduction in disability insurance benefits would be what would be required because we would only have the continuing revenue coming into that fund. So that is actually our sort of most soon date that we are concerned about at this point. There are many remedies for that to get OESI and DI back on track together. But our sense is, and we have always emphasized, and our trustees have always emphasized, enacting relatively soon allows you, the members of the Congress, more options to consider, allows you to give people advance warning of the changes that will be coming, whether it be more taxes or lower benefit levels, and also allows you to phase in the changes more gradually, which is really important.
Thank you. Mr. Van Hollen.
Thank you. Thank you, Mr. Chairman. Thank you both for your testimony. Let me just pick up on the Social Security questions here, and just so I understand this. With respect to the disability portion of Social Security, what you're saying is we would be required to make essentially a transfer of some of the trust fund revenues to that component of the program in the near future. Is that right?
Well, we could do that. Under the law, we cannot do that at this point. We had a similar situation in 1994 where the DI trust fund, disability insurance, was exhausting very quickly, and the OESI trust fund had plenty of money, and we simply had a reallocation of tax rates without changing the total tax rate for OESI and DI combined. The same could be done in order to get the solvency of the DI trust fund and the OESI trust fund back to be more similar.
Got it. And your testimony with regard to 2035, 2036, that testimony involved all components of the trust fund, correct?
That's assuming that we do not let the DI trust fund.
That's what I just want to make it clear. We're not talking about adding to the problem. Your numbers already assume we've addressed that issue.
Exactly.
Which we can, the way you said. Thank you. Just with respect to Social Security, there's been a piece of legislation that was introduced recently by two members of the Republican leadership to privatize Social Security. Have you had a chance to take a look at that?
I believe you might be referring to as the SAFE bill. I think.
Yeah, this is the legislation introduced by Congressman Hensarling and Sessions.
Right.
Yes.
We took a quick look at that. We have not done a formal estimate on that, but our sense is that particular proposal is, as put forth, is perhaps incomplete and not fully formed. As it is described, it would give people the option to begin to have their portion, half of their payroll taxes, directed to an account, and after 15 years to have the entirety of their payroll taxes directed to an account, including the employer's share also. And the cost to them would be that they would never get any benefits, they or their dependents. The problem in terms of the solvency of Social Security is that the reduction in payroll taxes for people who chose the option would occur right away. The reduction in benefits might occur with a 20 or 30-year delay. So this would put a considerable additional negative effect on the solvency of Social Security and would cause our trust fund exhaustion date to be earlier than 2036. We have dealt with several other proposals that would have some of the features, all of them, including the proposal put forth by Chairman Ryan, have in the past dealt with this issue by coming up with additional sources of revenue.
I understand, but I'm talking about this particular piece of legislation, just so I understand your testimony. It would accelerate the insolvency of the Social Security Trust Fund, correct?
It would absolutely, yes.
Thank you. Just turning to the Medicare issue, and Mr. Foster, thank you for your testimony and expertise on this issue. And you recognized in your testimony that there are lots of features in the Affordable Care Act that allow us to experiment with new incentives for the provision of care to focus more on coordination of care, rather than sort of the volume of care that is incentivized in some way in fee-for-service. And we had a lot of testimony yesterday from Secretary Sebelius, and I think everybody recognizes that those changes need to be made. If you repeal the Affordable Care Act, you, of course, eliminate the authority to move forward with those changes, do you not?
Yes, sir.
Let me just ask you with respect to the Medicare trust fund, because clearly we need to make the kind of changes to address those issues. But I think there's also a lot of misunderstanding about the Medicare trust fund. So just so people understand, the Medicare trust fund relates just to Medicare Part A, does it not?
There is a separate Medicare trust fund for Part A.
Right.
There is another trust fund for Parts B and D. Each have their own separate accounts within that trust fund.
Okay, but with respect to the payroll tax, your Medicare payroll tax, those revenues are directed for Part A, is that correct?
That's correct.
Okay. And when we talk about the year 2023, creating an issue with the solvency of a trust fund, that's what we're referring to, correct?
Yes, sir.
We're not referring to Parts B or C, Parts B or D, correct?
That's right. Those by their design for financing, barring some extraordinary circumstance, should never go broke.
Right. And that there was a deliberate decision by the Congress, correct, for example, with Part D prescription drugs, to fund it out of general revenue, either current revenues or through deficit spending, correct?
Yes, the primary form of financing for Part D is general revenues. There's also premiums paid by enrollees and special state payments, since the cost of drugs for dual beneficiaries transferred from Medicaid to Medicare.
Right. Now, we had a conversation, and you made the point, I think the chairman made the point, that we need to address some of the cost structures and incentives in the whole entire healthcare system. And if I could just put up a chart here that shows these are the per enrollee increases in healthcare costs. And as you can see, the average increase in costs for the Medicare for beneficiaries has been lower than in the private market, where it's been considerably higher. So essentially, if you were to say to someone who is enrolled in the Medicare program, they had to go out and get their insurance in the private market, they'd be facing substantial costs, would they not?
That question leads to a not straightforward comparison of the advantages and disadvantages of each form, private healthcare plans versus Medicare fee-for-service. And each one does have advantages and disadvantages. Comparisons of this type are a little difficult. You've done a couple of things that are very good. First of all, it's per capita rather than just total aggregate expenditures. Now, something else I would recommend, and this may or may not have been done here, is to do this for a similar package of benefits. For example, Medicare only gained drug coverage starting in 2006. So over some longer period of time, you end up counting drugs for Medicare some of the time, but not the rest of the time. The other thing is, if I read this correctly, this is based on 2002 to 2009.
Correct.
Over long periods of time, they tend to grow similarly, with Medicare at a slightly slower rate, as much as 1% slower on average, which
Right.
is a good difference. But over sub-periods, it can be quite a bit either way.
Right. No, I understand. I mean, if you look at the 50-year cycle, as you said, it's Medicare outperforms the private market on the per enrollee cost structure by about 1%. But in recent history, in fact, you see the numbers here. And I think there's general agreement here that we should try and reduce healthcare costs throughout the private market. Now, you raised some issues there as to what some of the potential negative consequences would be in doing that. One would be to provide a less incentive for research and development into new treatments and technologies, and maybe focusing more resources on providing care with the existing treatments. Is that correct?
Well, I mentioned that it would be nice to get the benefit of technology the way most other sectors of the economy have, where computers and cars and televisions and many other things have gotten relatively less expensive over time because of technology. For healthcare, we tend to get more and better new things and much more expensive. If the same approach were applied to developing less expensive treatments, for example, one-time use implantable defibrillators rather than many-time use defibrillators, that can be a good thing and help us save money.
Absolutely. Let me, just on the point, I'm going to finish with this because of the confusion. If we go to this next slide, and I want to make it very clear that we all know in this committee we face a big challenge on the future of Medicare. We have a very big difference of opinion on how to address it. But I think in our conversations about trust funds and payroll, we need to make clear a couple things. And this chart is taken from the data in your current report with respect to the shortfall. And when we're talking about the Part A trust fund, which is a lot of the language we hear all relates to the solvency of that trust fund in 2023. Does it not?
Yes, that's correct.
Okay. And so when you're looking at that specific component over the 75-year period, and you wanted to fully fund that, this represents the shortfall, does it not, in Part A?
That looks about right. I can't see the figures from here.
Okay.
But it's correct that under current law, if all the provisions for the payment rates are sustainable in the long range, then the problem to solve is not nearly as big as it used to be. It's of that order of magnitude.
Okay. And just for illustrative purposes, and we did the calculation, and this is for illustrative purposes only, in order to close the shortfall in the Part A, in the trust fund, what we all refer to as the trust fund, you would have to increase the Medicare payroll tax from 2.9% to 3.69%. Again, I'm not recommending that a proposal, but for illustrative purposes, people need to understand that when we're talking about solvency of the Part A trust fund, which is what most of the conversation's been about, that's what we're talking about. Now, everything in blue is funded out of general revenue, correct?
This is hospital insurance?
With possible exception of some, well, that's, let me correct that. Yes, it is. This is Medicare expenditures.
This is Medicare total?
Yeah.
Okay, a lot of the blue then is general revenues, a lot of it is payroll taxes, a lot of it is premiums.
Premiums, and the premium component. And there's no doubt there's a challenge, so we address that challenge in two ways. One, we have to make the reforms in the system. Again, big differences on how you do it. And then, as part of the broader conversation, you have to discuss the revenue component. And no one should be, I don't think anybody should be kidded into thinking you can solve this problem realistically on the revenue side. You can't. On the other hand, revenue, it should be part of this discussion, just like when you're talking about dealing with Social Security solvency, how much income is subject to the payroll tax as part of the income. So I just wanted to use this chart for the purposes of people understanding that when we're talking about the trust fund solvency, we're really talking about that red sliver up there with respect to the Medicare payroll taxes. And I won't, thank you very much, Mr. Chairman.
Mr. Campbell.
Thank you, Mr. Chairman. I will yield to the chairman.
Yeah, I just want to get into the Medicare cost curve. We have a chart from CBO, Table 3.1 in the long-term report that shows 4 time horizons. 3 out of those 4 time horizons, Medicare's cost growth per capita grew faster than other health insurance. When you widen the time horizon, it doesn't make the case that Medicare always costs less per enrollee than other health care. The only point I would make also is, look, if you pay providers 80 cents on the dollar, of course it's going to cost less. But you're paying them 80 cents on the dollar. I'd also say if we just focus on the Part A trust fund, which is going insolvent, we're ignoring the much larger liabilities. Part B and Part D, that's over $20 trillion in the trustee's report of unfunded liability as well. So it's important to look at the blue and the red because the entire system taken together, from testimony we heard yesterday from economists, 51% of Medicare is being cash flowed by the general fund. Bonds, we're borrowing. And so I don't think anybody's arguing that that's a sustainable situation. I think it's very clear. The sooner we deal with this problem, the better off everybody is. And if you just underpay providers, yeah, it's going to cost less, but our providers going to keep providing the benefit, I think is the question. With that, thank you.
Thank you. I'm just going to focus in my reduced time here, a couple of questions on understanding just where we are and what the straight line solutions are. First, Mr. Goss, we have a positive cash flow if you put both trust funds together right now. When do you project that turns negative?
In terms of cash flow, where we do not include the interest that is credited to the trust funds, in 2010, we turned to a negative cash flow for the combined OESI and DI trust funds. We actually were at a negative cash flow situation for the disability insurance trust fund starting in 1990 and starting in 2005. But as of 2010, on a combined basis, they have gone to negative cash flow.
Okay.
But the amount of interest that is credited to the trust funds exceeds that cash flow shortfall and will continue to through 2022.
And if we were to continue, when you say the trust fund is exhausted in 2036, that I presume means that in 2036 then payments, Social Security payments would have to be reduced to whatever the income was at that point?
Precisely, solely because our trust funds under the law do not have the authority to do any borrowing. That would mean that at that point, when we had 77 cents of tax revenue coming in for every dollar's worth of scheduled benefit, we would have only that much amount of money. We'd have to, somebody would have to make a decision as to how we would pay benefits.
If you wanted to increase payroll taxes today to just on a straight line basis to make both trust funds solvent within your 75-year window, what percentage increase in taxes would that take?
It would require an increase in the payroll tax rate from 12.4 by about a little bit over 2% of payroll. So that would be about a 1/6 increase in payroll taxes from 12.4 up to 14.6 roughly.
Okay. All right. Thank you very much. Mr. Foster, currently, what percentage of total Medicare expenditures are covered by Medicare taxes?
I can calculate that for you. It's most of it.
It's more than 50.
Oh, certainly. If you count the payroll taxes, and if you're talking about Part A only, or are you talking about total Medicare?
The whole system.
Okay, the payroll taxes would be a smaller proportion, but it would be in the neighborhood of 35 or 40% of the total.
Okay, isn't there's something in law that says that triggers that the president's supposed to issue some solution at a certain point? Are we at that point? What is that point? And has the president proposed something?
Yes, what you're referring to is a formal test instituted by the Medicare Modernization Act in 2003, which says if you take the difference between total Medicare outlays and total Medicare dedicated revenues, if that difference is expected to reach 45% of the total cost within 7 years, then the trustees have to issue a determination of excess general revenue Medicare funding. If you get two such determinations in two successive reports, that triggers a Medicare funding warning. And we issued the fifth such one with this current report. Then the president has the obligation to issue proposed legislation after.
Okay, final question, because I just
Sorry.
had to ask. Have you done any projections that assume, you talk about current law, but that assume that we do not lower physician reimbursement rates and that the Medicare reductions that are in the Obamacare law don't go into effect?
Yes, generally. That's the basis of our illustrative alternative to current law.
Okay.
Thank you. Mrs. Schwartz.
Thank you. I did want to get to Medicare, but just a couple things I did want to follow up on the Social Security. First, let me say I agree with and want to associate myself with the opening comments of the ranking member in terms of a balanced approach as we move forward, and that applies to our deficit reduction overall, that we need to be able to look at tax expenditures as well, and to only look at spending, whether it's non-defense discretionary, whether it's just Medicare, Social Security is its own piece is really just not a balanced approach, and we really need to have everything on the table. So I appreciate his comments and want to echo them. And I think the last a few answers actually suggest that even when we're looking at Social Security and Medicare, that we need a balanced approach, that a balanced approach allows us to look both at cost savings and potential for other revenues. Would be a way to approach it, to really look at everything on the table. I did want to, again, just following up on the discussion about Social Security, there was some discussion about, just for illustrative purposes, what percentage you'd need to increase the tax in order to get to solvency. And you did answer that question of having to go to 2.9 to 3.69. Again, that is just for illustrative purposes. Just wanted to quickly, if you just answer, because I do want to get to Medicare, if you just answer that there are other options there as well. The cap on the payroll income that's applied, the taxes are applied to, for example. Have you looked at other opportunities for ways we might be able to bring in some additional revenues so that maybe the cuts don't have to be so drastic, or that we could increase the solvency of the trust fund?
We certainly have one little clarification Rick and I were just talking about is the going from 2.9 to about 3.7. That's the Medicare Part A.
I'm sorry, and it was
solution.
12.4.
For us, it would be 12.4 up to about 14.6. Well, it would be an immediate tax rate increase on the payroll tax that would be sufficient to carry
But if
us
we
for
didn't want to do a
75 years.
tax rate
But if
increase
we-
at all, there are other options.
If we didn't want to do that, there have been several other possibilities that have been considered. One would be to, instead of raising the tax rate on the earnings up to our current taxable maximum, which is $106,800, would be to, in fact, raise that taxable maximum itself. Now, that would be, in fact, an increase in the tax rate from nothing to
For some-
12.4 for the earnings above that. One popular proposal that's been put forth in many places by both the Fiscal Commission, the President's Fiscal Commission, and by the Domenici-Rivlin Commission would be to gradually raise the payroll tax rate, not the payroll, but to raise the taxable maximum up to cover not ultimately about 83%, but about 90%.
Which is where it started.
Which is where we were back in 83, 84. And that would solve about a third of our long-term problem. If we eliminated the taxable maximum entirely, as is the case for the Medicare 2.9%, that would basically eliminate our 75-year shortfall. Well, if I may, just one other item that I would want to mention, another revenue enhancement proposal that is put forth actually in Chairman Ryan's proposal and was picked up in the Domenici-Rivlin proposal for the Bipartisan Policy Center was to tax employer-sponsored group health insurance premiums, and that would cover about half of our long-term shortfall.
But thank you. I appreciate the fact that there are other options for us to explore. So I don't have a lot of time left, but I really appreciate both of you also adding really good information about why we're in some of this situation. But, we anticipated all the baby boomers in Social Security Trust Fund. Good, smart move. But for some reason, we did not in Medicare. It seems to be that those same seniors are a surprise to the Medicare Trust Fund. The additional, it's not almost a doubling, not quite, but we're going from 40 million to almost 74 million seniors who will be covered under Medicare. And that simple demographic change is certainly a very significant burden, particularly since we are seeing fewer workers. I just wanted you, if you could, in a little time to do this, speak to the Republican proposal to end Medicare as we know it and to create a voucher program. At the same time, we will have these 74 million seniors in the current system under Medicare. And particularly if the Republicans were successful at their second goal, which is to repeal the Accountable Care Act and take away all of the cost savings that are available, potentially you talked about, Mr. Foster, in incentivizing payments that would reduce costs and improve quality. What does that do to our deficit? Does that not explode the deficit over the next 10 to 20 years?
On the latter question, the Affordable Care Act clearly had major savings provisions for Medicare in it. We estimated at the first 10 years a total of $575 billion between lower expenditures and or higher taxes. So if that were repealed, you'd have to do something else.
But what about the notion of having these double group? It would be interesting to know your answer to that. My time is up.
Mr. Price.
Thank you, Mr. Chairman, and I want to thank the witnesses as well for enlightening us today. Our colleagues on the other side of the aisle, and Ms. Schwartz just did as well, talked about our desire to end Medicare. The fact of the matter is, what our proposal does, as you all well know, is to save Medicare, and she categorizes it as a voucher program. As you also know, it's not a voucher program at all. Program of premium support, which is remarkably different. In fact, it's something that was actually proposed toward the end of the Clinton administration by friends of folks on the other side of the aisle. I want to ask a number of questions. First, I want to follow up on Mr. Campbell's line, Mr. Foster, about the 5 straight years of this Medicare warning that has been issued. And at the end, when you have 2 of those years in a row, then it's the obligation, is it not, of the president to then make some kind of recommendation about how you get out of this situation of having Medicare in such dire financial straits, correct?
Yes, sir. Section 802 of the Medicare Modernization Act puts in a requirement for the president to recommend ways to address.
And have you received any recommendations from this president on that?
Not to my knowledge.
Thank you. You also stated in your testimony that the Medicare payment, quote, the Medicare payment may be inadequate, unquote, as it relates to physicians and other providers. As a physician, we talk about numbers all day long, but what happens when Medicare payments are inadequate?
We'd like not to find out, but as you can imagine, especially in your situation, but any of us, if we have a job, if we are paid a certain amount for the services or the goods we provide, and what we're paid ends up not being adequate to keep us in business, then we're going to go out of business or turn our business elsewhere. So the potential access problems could be very serious. And we see with the Medicaid program, of course, in some states, the payment rates, particularly for physicians, are quite low, and access to care is quite a problem.
So the access that patients have to physicians may be markedly limited.
Well, if the 30% reduction went through, for example, come January 1st, I think there would be a noticeable reaction, very noticeable.
We had Secretary Sebelius here yesterday to talk about, and other witnesses to talk about the Independent Payment Advisory Board, the IPAB, which I believe is a denial of care board to seniors. The largest hammer that they have, isn't it true that the largest hammer that they have is to deny payment to physicians for services that are being proposed to be rendered or have already been rendered? Is that correct?
They have the authority to make recommendations for payment rates, not just for physicians, but for other providers as well. They can do some other things in addition, but the other ones are less clear as to their effect.
But they have the authority, would have the authority to deny payment for a certain service or a certain procedure.
That I'm not so clear about. In other words, there is language in the law that governs what kinds of recommendations they can make and not make. In terms of a specific procedure, for example, they clearly can't deny care for the treatment of heart disease. Now, could they deny care for a particular method of treating heart disease that they deem to be of little value? That I don't know.
And I think it is that is the case, so that patients and physicians would no longer be the ones making the decision about whether or not that occurs. It would be this board. And if in fact the board denied payment for a service, then isn't that the same kind of thing that you referred to earlier, which is when the Medicare payment is inadequate?
Well, it's in this hypothetical, you get the same result.
The same result.
The whole point of Medicare is to provide health care to older people and disabled people.
In my few brief seconds left, I want to touch on your report that you've offered here. Currently assumes the effects of the health reform bill that was passed last year on Medicare, correct?
Yes, the current law projections assume all elements of current law.
And under these assumptions, when will the Medicare Part A trust fund be exhausted?
Under current law, the Part A trust fund would be exhausted in the year 2024.
So the program itself right now is unsustainable under current law and changes are necessary.
Yes, certainly the Part A part, and you can argue and have a fun time with the other parts.
Thank you.
Mr. Blumenauer.
Thank you. I just following up on what Dr. Price was talking about, where there may be some decision about certain procedures for heart treatment that conceivably could be restricted or modified in some form. Isn't that what happens with private insurance right now? Doesn't private insurance set standards about what they'll reimburse? They go over doctor billings. They don't cover every procedure that a patient or a doctor may want. Isn't that the case?
I would say that's correct, not only for Medicare, but also Medicaid and for private health insurance.
That's how
across the
private, but I
board.
want to just clarify that that's not unique to government. Private insurance sets standards about, they negotiate rates or they disallow some treatment if they don't think it's effective or it's not within the scope of the, isn't that what happens every single day?
Every payer of health care has medical review boards that decide what things are covered and payable
Okay.
and what things are not. Very, very few things are denied, I might add. Yeah, I'll stick with that.
We'll have some fun with that later.
Okay.
Because insurance companies do set rates. They allow some things, they deny others. But let's, I want to get to the notion here. You and I have talked before. You think that some of the things that's in the Affordable Care Act is not sustainable politically. I find it interesting that the cuts that would take, that the burden that would be assumed from day one, where it's all of a sudden 60% of the premium liability, increasing over time in terms of the out of dollar pocket, is equally unsustainable, maybe more so. But we have difficulty evaluating that. But I want to get to one area where I think your expertise should be undeniable, and that is looking at trend lines. Now, Mr. Ryan said that there were some periods that you could pick that showed that it might be higher or lower. My understanding is for the last 40 years, private insurance premiums have been going up 9.3% on average.
I can check that figure for
Would you
but I don't
please?
know the answer off the top
But
of my head.
my question is, how is that sustainable? I'd love to see a chart from you about what would happen if we're going to load all our senior citizens into the private insurance market, but we just take the trend line for the last 40 years, where it is above inflation, it's significantly above the increase in productivity of what we've had in the past or anybody thinks we're going to have in the future. And I'd like you to chart what that looks like in 2075. If we're going to put all our eggs in that basket, if we could just have one chart that shows, given a rate of the last 40 years of what private insurance premiums or healthcare costs are going to be in 2075 compared to inflation and compared to increase in national productivity. Mr. Chairman, I'm going to suggest that that chart is going to be very vivid. I mean, you throw things up over time about, our entitlements aren't sustainable. No quarrel. But the path we're on now is worse. And if we're going to play that game, I think we ought to at least look at what it is going to be in 2075 if, absent the efforts in the Affordable Care Act, which used to be bipartisan to control costs, and I think ultimately we will do this when we get through the games over the next 2 or 4 years, but just model your plan, entire private sector based on 40 years experience compared to the increase in productivity, and I think that's not on the charts that you give us, and I think it's going to be a very vivid portrayal of why the wishing away the dynamic that we've all been wrestling with for 40 years, and politicians have blinked time and time again, and they will on SGR. That's why we have an iPod or whatever it is to try and stiffen this. Excuse me, IPAP, I guess it is. because I think this is an iPad. But I think that will be a pretty vivid illustration of why my time is up. Okay.
Sorry. I was into this, though, so you were...
Well,
running
so was
down.
I.
Yeah, I was...
So was I. I appreciate the correction of the terminology.
Sure, Mr. Langford.
It'd be interesting to note as well how much of a cost shift there has been because of the lower reimbursement rates of Medicare that they have to pick up additional in the private insurance market, and how the private insurance market is not only paying their tax for Medicare, but also paying as well an additional amount in their own insurance rates to help cover the cost of Medicare. But we'll be able to track that as well from there. Let me ask a question about Social Security. You made a very stark statement, Mr. Goss, about the disability. 2018 is very, very close. The stats I was looking at show that disability has grown from 1990 to the present by 420%. With this very rapid rise in disability, can you tell me why that we have this rapid rise?
Well, in fact, the disability insurance program is, in a sense, a preview of what is going to be happening to our retirement portion of the program. The baby boom generation that we talk about, and by the way, we talk about the baby boom generation as the baby boom principally because the birth rates dropped so much after them. If birth rates had stayed higher, they wouldn't look so much like a boom. But the fact that we have the baby boom generation born 1946 through 1965, they, in fact, are people who are, I think, today between ages 44 and 65. Those are precisely the ages at which we have the bulk of our people receiving disability insurance benefits now. So we are right now sort of at the apex, at the height of the point where the baby boom generation is creating the surge, the highest level, arguably, relatively speaking, for disability insurance cost. The rate of growth in disability insurance should be expected to be slower in the future at an aggregate level and percent of GDP. And
Do you have an idea when that slows down?
That should be slowing down just in the next several years. Actually, our incidence rates of disability on an age-sex specific basis have not been growing that much. It's largely that our population under 65 has been shifting because of the baby boom towards being many more in the ages that are prime disability.
Yeah, that's very helpful to be able to know. Thank you. Let me ask you a question, Mr. Foster. I'm still trying to wrap my head around the estimates currently that we're facing with the 2024 insolvency of Part A. That assumes to get that number, we have to cut doctors' reimbursement 30%, or just not fix it, basically, on this 30% amount.
If I could jump in and
Sure, please do.
make a slight correction. The physician payments come out of the Part B account,
Okay, I'm sorry.
so it doesn't affect Part A.
Okay. So then you had said there's a reduction in payments in the Affordable Care Act. How does that involve in this, the Part A?
It affects all Part A providers and will reduce their rate of growth in the payment updates each year by about 1.1% per year.
Okay.
So instead of an update of maybe 3.3%, it might be 2.2%.
Okay. I was in a meeting in June with Secretary Geithner, and we were going through some of the specifics of the President's proposal to do savings in different areas, and obviously we have a major need for that. One of the proposals that he stated specifically was $100 billion in savings in the next 10 years in Medicaid through lowering the reimbursement rate to doctors and hospitals, and then also some flexibility in the states. And then $250 billion in savings in Medicare, in addition to what's already been done by lowering the reimbursement rate to doctors, hospitals, and drug providers. Now, that statement was fairly stark to me based on some of the statements that you just made, saying that you're not sure it's sustainable now, both for B and dropping reimbursements for physicians 30%, and A, and lowering reimbursements and the payments that are happening, and then an additional $250 billion in reducing reimbursements. Do you think that's sustainable? What do you think the consequences of that would be?
On the physician side, I think it's quite clear. I mean, I won't ask for any volunteers in here, but I'm sure nobody would raise their hand and say, yes, let's cut the payment rates for physicians by 30%.
Right.
So that's going to be changed. I think it goes without question. It's unsustainable immediately. Now, regarding the productivity adjustments, the slower payment updates for most other kinds of healthcare providers, that's much more gradual. It's a little over % per year. And over the long range, as we saw in the charts earlier, it accumulates to a very large difference, which is disconcerting at best. Over 10 years, it's not to say that couldn't work just fine. That remains to be seen. And of course, some providers are on the margin right now, and
Right.
others are doing
I'm
much
going
better.
back to your previous comment of informing us before something bad happens.
Right.
Yeah. Well, I appreciate that, and my time has expired.
Could I
I'll
just
go back.
say, just a point of information, that it is true under the Accountable Care Act that we also did increase reimbursements for primary care physicians, nurse practitioners, and PAs to recognizing their lower reimbursement.
Thank you, gentlelady. Mr. Pasquarello.
I just wanted to follow up, Mr. Chairman, on what a gentleman from Oregon was mentioning before, and that is the real cost shift that we're talking about here. Rests with the folks who have no coverage whatsoever and wind up in emergency rooms. That's the real cost shift. They wind up there. And if we don't recognize that. And Mr. Chairman, I tried to ask you a question earlier. I'm going to ask it now. Thank you.
Your time.
I tried to ask you a question earlier about your famous chart. You had it up yesterday.
Chart number 1 or 2?
That's the one,
Okay.
right up there. About physician payments. If I could get that chart, we got it up there right now. Does this chart, or doesn't this chart assume a 30% cut to SGR, the sustainable growth rate, Mr. Chairman?
Mr. Foster.
Correct?
Mr. Foster, this is chart 7 in your testimony. You want to provide him the answer?
Yes, sir, it does.
Thank you. Well, don't you think, Mr. Chairman, that that's a bit pessimistic and not in line with the current reality, since we, as a Congress, in fact, I think
I agree.
we mentioned it before,
Yeah.
we've averted that, these SGR cuts for the last 10 years and are currently working in Ways and Means, you're a member there as well, on a long-term fix. Isn't that true?
I think that's right, and I think that's why
Thank
that
you.
lends more credence to the appendix that Mr. Foster put in his report, showing that the true unfunded liability on Medicare is more at $37 trillion than not.
Well, let me ask you this question, then, Mr. Chairman. Does it take into account the payments that are made to doctors for health information technology, electronic medical records? Does it or does it not?
Well, mind you, even if we plug that hole, doctors are still getting paid 80 cents on the dollar.
What about quality, what about bonuses for quality reporting?
Are you talking about
Include that.
PPACA? Yeah, PPACA. So if you take a look at this chart, you'll see it's at 80%, and then it goes off a cliff. That cliff is the SGR.
Well, you
So let's assume we plug the SGR, the cliff doesn't occur, the slope still goes down, but starting at 80%. So that means instead of paying physicians next year 60 cents on the dollar, we'll plug the hole and pay them 80 cents on the dollar, and that still goes down to a lower amount. And that means then we're moving more toward a $37 trillion unfunded liability than a $20.
But we're here today to address the problems in Medicare and Social Security, Mr. Chairman. I think what we need to do is have real detailed explanations about the charts that you put up there, we put up there. It doesn't matter who puts the charts up. You can't just slide those charts given assumptions. What does that mean?
Okay,
Mr.
so the next
Foster,
time we put the actuary's
I didn't ask
chart
a
up, we'll tell you
question,
we're
Mr.
putting up the
Chairman.
actuary's chart.
Yeah, I didn't ask you.
See the source down there? Actuary.
Mr. Foster, at yesterday's hearing on the IPAB, one of my colleagues attributed Medicare's insolvency to the Democratic plan. I just want to make clear what creates solvency problems and what does not. Healthcare reform, which is fully paid for, is not to blame for Medicare's solvency.
Would the gentleman yield on that point then?
Sure.
So if we're to assume what you say, that these cuts will never occur, then your health care bill is not paid for.
We know that the health care bill is paid for.
Well, no, you're saying it's paid
excuse me,
for.
we painfully laid it out very clearly.
can't have it both
as
ways.
very different from what.
Either these cuts do not
Focus
occur
on-
and it's not paid for, or these cuts do occur and it's
Can I
paid for.
reclaim my time?
Yes, you may.
Would the
Very
gentleman,
diff- Very different, just make me this one point. Very different from what you did in your prescription drug plan of 8 years ago, we didn't pay for anything.
May I ask
We
you a
didn't pay
question?
for anything.
Would you yield?
Sure.
If these cuts do not occur, then your bill is not paid for. If these cuts do occur, then on paper your bill is paid for, and this happens.
Well, this is my point. This is my point. Well, look, we're trying to provide services to people. We're trying to provide those services for everybody. But you refer to tax cuts. Many of you gentlemen on the other side and ladies refer to tax cuts. We know that the deficit that we're addressing, and you're not going to respond to the deficit, and you're not going to clear up the deficit and by blaming Social Security or Medicare or the recipients of those benefits. 3/5 of the deficit by 20. Let me finish.
Go ahead and
you.
finish. We're beyond your time, but since I took some of it, go ahead.
I appreciate
wrap it up.
that very much, Mr. Chairman. You're very kind to me today.
Don't push it. Come on,
I
let's
said
go.
today. The tax cuts of 2001 and
Okay.
2003 are going to mean by 2019, and you like figures, Mr. Chairman.
All right, I got you where you're going.
You dig figures.
I get where
By
you're going.
2019, 3/5 of the deficit will be as a result of the extended tax cuts that you supported,
All right.
you voted for, and you think will bring us to the promised land.
We could go on and
in
on.
2011.
We go on and on, Ms. Black.
No, it's not going on and on. It's the truth.
Thank you, Mr. Chairman, and thank you, panelists, for being here today. Mr. Foster, I would like to turn to the issue of how income is calculated for the federal health programs. And I know that this issue was mentioned in the Energy and Commerce hearing where you testified. I hope that you might be able to help elaborate for this committee the implications for including the MAGI, or what they call the Modified Adjusted Gross Income, which is created by the Affordable Care Act, and specifically by requiring states to use the Modified Adjusted Gross Income as defined in the Internal Revenue Code.
Yes, ma'am, I'd be glad to do that. This has to do with the expansion of the Medicaid program under the Affordable Care Act and the creation of the health insurance exchanges. You need to have a consistent definition of income to determine eligibility for Medicaid and the level of your exchange federal subsidies to avoid any gaps or overlaps. So to handle that, Congress chose to use the definition of modified adjusted gross income for this purpose. It's readily available. The problem is that for many or most Social Security beneficiaries, little or none of their Social Security benefits are included in adjusted gross income, which is the first step in determining the modified version. So as a result, if you have Social Security beneficiaries under 65 who don't qualify for Medicare yet, and that's a lot of them, then the income test for them is not up to 133% plus 5% of income, of all income. It leaves out their Social Security benefits in many cases, and in some examples we've done, the test can actually be more like 300 to 400% at the extreme, which is probably not intended.
And given that, and I know yesterday or maybe Monday was when the initial rulemaking for the state exchanges did come out. And so I know this may be a little difficult for you to answer, but I'm interested to hear the effects on the state exchange premium credits and the cost-sharing subsidies and Medicaid. What do you think the effect of this is going to be on the states?
For the states, you have the issue of their portion of the cost for Medicaid of the expansion. And of course, for the first 3 years, the federal government pays the entire cost for the expansion population. And then it grades down to 90% if I remember correctly. On the exchanges, you still have an issue of the eligibility in the following sense. If you have somebody and you include their Social Security benefits in their total income, and on that basis they would qualify, say, for a given level of premium assistance and cost-sharing assistance, but now you don't count their Social Security benefits, they'll qualify for a higher level because they'll look more low income. So it shifts people on that eligibility curve and puts them into brackets where they get a greater subsidy.
And I've heard that this could be 3 to 5 million more individuals who could be added to Medicaid by 2014. I have estimates from CBO that closing this loophole that was created by the Affordable Care Act could save well over $10 billion over 10 years. And that's why I have legislation that I'm going to be introducing early next week to establish a formula in the revenue code that accurately reflects an individual's eligibility for certain health care related programs, and that is in line with the eligibility requirements for other government programs such as SSI, SNAP, TANF, and unemployment insurance, to hopefully get at this loophole to close it so that the states will not be terribly affected, and that it will be a more fair system, as I say, in those other programs. And so the bill would ensure that health care programs are available to those who need it the most, rather than going to people who may be outside of that because of this loophole. And the bill also would be about ensuring fairness, as the health care law is now written. And some individuals would get a significant break on their health care premiums. So making this a fairness issue is where I'm hoping to go with this bill that would close this loophole. Do you have any comments in my few 8 seconds, 7 seconds that's left on this?
Well, I try to stay out of policy issues, but this is one where I think it changes in order.
Thank you. I yield back my time.
Ms. Wasserman-Schultz.
Thank you, Mr. Chairman. My first question is of Mr. Goss on the Social Security privatization in the Ryan plan. What the Ryan plan does is it proposes to set up private accounts by diverting Social Security payroll taxes. What was your estimate of the cost of diverting those payroll contributions?
Thank you. Let's see, we did, this is a year or two ago when we did the last version of the roadmap. And there were a number of changes in that would actually lower the scheduled level of Social Security benefits. The amount of payroll tax contributions that would be redirected, we estimated over the 75-year period at 1.74% of payroll would be redirected to the personal accounts.
Now, the Ryan plan offset that increased cost to Social Security through its benefit cuts under progressive price indexing. Is that right?
In part, I think it might be a more appropriate fundamental way to look at the way the Ryan roadmap worked was first there was in effect a reform to the Social Security structural program itself, and it had 3 basic components.
And that reform was a privatization of Social Security.
Well, there were, first of all, just the basic Social Security program as we know it without the privatization aspect, that the progressive price indexing, a change in the normal retirement age, and the additional revenue from the taxation.
Personal accounts are the equivalent of privatization.
Right,
Mr. Ryan.
but personal accounts were also included, and money was taken out of the trust funds to fund the personal accounts, but then people who participated in that would have a reduction in the benefits they would subsequently receive.
So there would be a reduction in benefits that individuals would personally receive under that plan?
For those, absolutely, yes.
Yes, okay.
May the gentlelady yield for a quick question?
You are pretty rigid about holding to the 5 minutes,
Okay.
Mr. Chairman, so.
There's a guarantee that you don't lose money if you put it in your
Mr. Chairman,
personal account,
I
correct?
didn't yield. If you give me
All right.
time
All
beyond
right.
the 5
Yeah.
minutes, then I'd be glad to yield. Thank you. Moving on, it really deeply concerns me, your response deeply concerns me that there is a plan on the table that has been proposed by the chairman repeatedly that an expert acknowledges would reduce benefits, would actually jeopardize the long-term solvency, create an insolvent, not address the long-term solvency problems that we have with Social Security, and risk the safety net that is clearly in place now for Social Security beneficiaries. And I'm particularly concerned about the impact on women because, sorry to the men in the room, but women generally live longer than men. So there is a greater need for Social Security benefits to be in place. To keep the average Social Security benefit is about $12,000 a year to help an individual keep a roof over their head, pay for their prescriptions, and that's even needed even longer for women. So at the end of the day, to me, it's very troubling that, that there would be a plan on the table that would privatize Social Security. Let me turn to Medicare in my final about minute and a half. Mr. Foster, Republicans have said that they want to reduce the costs for seniors, but I don't know how they can say that with a clear conscience when the Affordable Care Act does reduce costs for seniors, and the Ryan plan actually adds $6,000 or more in costs to Medicare beneficiaries. I mean, just to review what the Affordable Care Act does, it reduces the out-of-pocket costs for fee-for-service Medicare beneficiaries. Part B premiums decline by more than $200 per beneficiary by 2019. Co-insurance declines by more than $200 per beneficiary by 2019. And although Part D beneficiaries see a slight increase in premiums, isn't it right that that's actually offset by the closing of the donut hole and the actual reduction in the amount of out-of-pocket costs for seniors?
For the Part D beneficiaries, that's correct.
Okay. Thank you, Mr. Chairman. I yield back.
Mr. Heelskamp, would you yield up 30 seconds?
Absolutely, Mr. Chairman.
Mr. Goss, can you just quickly answer questions about the bill I sent you about 2.5 years ago? Number one, does it make Social Security solvent? Number two, does it raise the minimum benefits to keep every senior out of poverty? Number three, does it have a benefit guarantee for those people who elect to have those voluntary personal accounts?
Yes, it does result in solvency. There is a minimum a low earner benefit enhancement. And as for the guarantee in the form that we scored most recently, there is a guarantee that the personal account would accumulate by retirement with a non-negative real return.
Thank you.
It would not yield less than CPI.
Thank you, Mr. Heelskamp.
Thank you, Mr. Chairman.
If I could just ask a question on that really quickly.
Well,
Would
it's
that be
his
okay?
turn. It's Heelskamp's time.
Mr. Chairman, I had
but-
40 seconds left that I'd be glad to yield to the ranking member.
Sorry,
Oh,
we're
he
already at
yielded to you?
Heelskamp time.
Oh, okay, you're okay. I never yelled.
Okay. Thank you, Mr. Chairman, and I believe I have a chart. If we put up my chart from staff. Yes, there's a chart up there. Yesterday, I was particularly disturbed, as were many constituents, by a statement the President of the United States made, and the question would be to Mr. Goss. And it said something to the effect from the President that I cannot guarantee that those checks go out on August 3rd if we haven't resolved this issue. It's in reference to Social Security checks, and it's in reference to the debt ceiling issue. And look at a chart that was sourced the U.S. Treasury, prepared by GS Global ECS Research. And I wonder if you can explain to me how the checks would not go out on August 3rd. Under what circumstances would Social Security checks be withheld?
I wish I could give you a definitive answer to that. I think you'd have to talk to people at Department of the Treasury, quite frankly. What we know and understand is that whenever we pay any money out of the Social Security trust funds, we must redeem bonds. And when we redeem bonds, that actually lowers the amount of debt subject to ceiling. However, in order to pay the benefits, the Treasury must at the same time then issue bonds to the public, which therefore increases the debt subject to the ceiling. So there is, in effect, kind of an offset between the two. The exact mechanism by which that happens, it was very complicated, and it's Department of Treasury and the Republic Debt that would have to speak to that issue.
Thank you. I appreciate that. So you're not familiar with how the Department of Treasury manages their resources in terms of paying Social Security checks?
We are to a degree, but there are many detailed intricacies about how exactly it's handled with respect to the timing of the redemption of the Social Security bonds and then the issuance of debt to the public, and whether or not that process, if not done exactly simultaneously, would in fact breach the debt ceiling if we were already at it, is, I think, really the issue.
And I appreciate that. And for members of the committee, if we take a look at that chart, and this is cumulative cash flows, and the line is the receipts. And you see throughout the end of the month of August, that line of receipts exceeds our expenses, including essential defense, Medicare, Social Security, interest, and yes, and then the receipts line. And I was trying to figure out, and I guess we'll have to ask the Department of Treasury, which we're having very difficulty getting answers from them. But I see under no circumstances, unless it was a political decision, that the administration would refuse or would withhold Social Security checks because there are sufficient receipts. And I appreciate the opportunity to make that statement. I wish we could have a little more information. And folks at the Social Security Administration, have they asked that question? I mean, you're going to be asked, when do you cut those checks, and when are you told not to cut those checks?
Well, the responsibility of the Social Security Administration per se, my boss, Commissioner Astrew, is to in fact determine how much in the way of benefit payments people are supposed to receive. And we send that information actually over to the Department of Treasury. They're the ones that actually send out the payments,
Okay.
whether it's electronic funds transfer or checks.
Well, can I ask you to ask the Treasury Department, because the administration just really doesn't want to provide information, and when you stand on the evening news and make a statement that 40-some million Americans are going to not receive their checks, could you ask the administration, are they planning on withholding those checks, and is there a reason they wouldn't make those payments on August 3rd?
I will be happy to join
Thank
you
you.
in raising that question.
Very good. Thank you. I appreciate it. I yield back my time.
Ms. Castor, you're recognized.
Thank you, Madam Chair. While Social Security is not a driver of the deficit and it is not an immediate crisis, I think hopefully we can all agree that it's vitally important to work together to strengthen the Social Security Trust Fund. Mr. Goss, you know, when I talk to folks at home, you know what they're most surprised to learn when you're talking about the basics of Social Security? They're surprised to learn that Americans pay into Social Security, but only up to $106,000, $106,800. And anything higher than that is exempted. I think I heard you share with Ms. Schwartz earlier that that cap has been adjusted over time. Can you kind of lay out the changes in that that taxable maximum over maybe the past couple of decades?
For I believe it's since about 1970 to 1980, we have enacted in the law, you enacted into law, an automatic adjustment mechanism for this taxable maximum amount. And it grows with the average wage in the U.S. economy, which we project will be at about a 4% average annual rate in the future. So the taxable maximum does grow at that rate. It has grown at that rate over the historical period. I think there was a comment earlier, though, about the percentage of all earnings in the U.S. economy that are covered under Social Security, and the percentage of those earnings that, in fact, are subject to our payroll tax, that is, fall below the $106,800. That's currently around 84%. We expect by the year 2020 that to be around 83%. It did reach a high watermark in recent history of about 90% back in 1983 and 4. The fact that it has drifted down has been due to a widely known and understood phenomenon in our economy that there's been a dispersion of earnings, meaning that people at the highest income levels have tended to have a faster rate of increase in earnings than at the lower income levels. That has caused a shift towards more of the total earnings in the economy being above our taxable maximum, and it's what's pulled down our share of those taxes.
That's very interesting because the other thing I hear from folks when you're just talking about the basics of Social Security is that folks are very interested in making sure the trust fund is healthy and solvent and I think I'm a little younger than a baby boomer, so my generation wants it to be around as this baby boom bubble moves through, and they think that, gosh, if you can raise that cap, maybe even over time, and the Rivlin-Domenici Commission looked at it, and others have studied, if you could raise that cap over time, is it true we could make the trust fund solvent without any change in the retirement age and without any change in benefits? Is that right?
Well, the estimates we have done is if we were to, as is true with the 2.9% Part A Medicare tax, which has no limit whatever, it's charged on all earnings at any level. If we were to do the same for the 12.4% Social Security tax, that would generate revenue, in fact, in excess of the amount needed to fully finance Social Security benefits through the 75-year period through 2085. If, however, we were to give benefit credit for the additional earnings that would be subject to tax under our current benefit formula, it would fall somewhat short of being able to cover the whole 75-year period, but would cover an awful lot of the cost.
Thank you. I think that's a smart way to shore up the trust fund and strengthen Social Security and keep the promise to our older Americans that Social Security is going to be there for them. On Medicare, Mr. Foster, thank you very much for being here. When the Medicare Part D was added and came online in 2006, people are very surprised to learn that it wasn't paid for, that there was no dedicated funding, no offsets, no revenue raisers, and the CBO has estimated that that is going to cost us $1 trillion from 2012 to 2021. Do you agree with that CBO number?
Well, I'm sure it's in the right ballpark. I could add it up from our own estimates for you.
And it's very interesting as we discuss all of the debt policy. The Affordable Care Act, remember, was paid for. $575 billion over 10 years, isn't that correct?
Yes, it was.
Yeah, so there's a difference when it comes to Medicare and who are the good fiscal stewards of the Medicare initiative. That Medicare Part D was added at a time the Bush administration was already projecting the largest debt in American history. I think that was very poor public policy and very poor fiscal policy. But there is a proposal that has been introduced by Mr. Waxman and Mr. Dingell that could help us shore up, find additional savings for Medicare Part D. Are you familiar?
The gentle lady's time has expired.
Okay, let me just highlight then to everyone the Medicare Drug Savings Act of 2011, H.R. 2190. CBO estimates that we can bring in over $112 billion in Medicare Part D. So I highlight to everyone. Thank you very much.
Thank you. The gentleman from Wisconsin, Mr. Ribble, is recognized.
Thank you, Madam Chair. Just would make one quick response. If we reduce physician payments from about 80 cents on a dollar to 33 cents on a dollar and raise taxes by $1 trillion, I suppose we could fund some things. And so I'd like to go back to Mr. Goss to try to clarify some of the questions and to follow up on Mr. Hillskamp's line of questioning before. I'm trying to get my hands around the Social Security Trust Fund. Where does the money exist? Is it just on a balance sheet someplace? Does it just show up on a ledger, or is there an account with money in it? Where is all this money?
Well, when Social Security or any of the trust funds in the federal sector have excess revenue coming in, excess dedicated taxes, that money is in fact received by the general fund of the Treasury, and securities, which are required by law to be interest-bearing securities backed by the full faith and credit of the U.S. government, are then issued to the trust funds. So the trust funds holds those securities, much as you might with a double-E bond or a Treasury bond that you have in your own possession, or folks overseas, for that matter, in terms of publicly held debt. Actually, interestingly, the debt obligations issued to the trust funds are referred to by the Department of Treasury as public debt obligations. They're not publicly held debt obligations, obviously, but they're referred to as public debt obligations. So they are not a pile of dollar bills, obviously, any more than if we go and put $100 into the savings and loan down the street, they will go out and invest it or put it to some use later. What counts is our ability, when we need that money, to be able to come and get it back. So far, in all of history, whenever the trust funds have needed money, and it's been ever since 2005 that the DI trust fund has needed to be pulling money out of the trust fund, it has been there and it has been made good.
But if I took and invested money in a bank and they went and invested it someplace else and I wanted to go get it back, and they said to me, gee whiz, you can't have it back because I've got to go borrow it, what would that do to your confidence about it?
Well, if they said you could not have it back, that would be a problem. Actually, I think we had a situation like that fairly recently with some of the big banks, and they came to the government to bail them out.
Yeah.
But in terms of the Social Security trust funds, that is a concern. And this is the reason that the trust funds are required to invest in interest-bearing securities backed by the full faith and credit of the government, so that, in fact, there is thought not to be that issue of concerns of being able to get the money when you need it. It really, for that to be undone, I think would require an act of Congress to say that the money would not be available.
Okay. In your testimony, you said, first, assets in the trust fund have been borrowed by the rest of the government in lieu of additional borrowing directly from the public. What we're speaking about here, correct? Publicly held debt, currently about 10 trillion, is lower than the federal debt of about 14 trillion, solely due to borrowing from the trust funds. That $4 trillion, is that just surplus, or is that the total amount?
Well, the $4 trillion is, in fact, the accumulated amount of excess revenues that have been brought in by the trust funds.
Since the beginning of the
Since the
creation of it.
beginning of time, in Social Security's case, since the year 1937, Medicare since, 1965, it's the excess of revenues that have been brought in with accumulated interest that are held in those funds. And in effect, had they not been brought in that excess and the rest of government had spent what it spent and taxed what it's taxed, we would still have the rest of government owing somebody $14.3 trillion. It's just that it would not have $4 trillion of that, in effect, borrowed from the trust funds. It would have to all be borrowed from the
And if,
public.
if that had been the case, it would have been transparent to the American people, and the president wouldn't go on TV and say, if we don't raise the debt limit, we can't send our Social Security checks out. Is that accurate? If that money had been in, like Al Gore campaigned on a few years ago, in a lockbox.
Well, that's very difficult. The definition of what exactly a lockbox would be has never been clear to me.
Yeah.
So I'm not sure that we can really answer exactly what have happened under that circumstance.
But your testimony would imply that it was borrowed, not imply, it states, was borrowed by the rest of the government in lieu of additional borrowing. So I'm assuming that the federal government used it just to spend on its normal activities and basically continue to fund other things other than Social Security.
Well, the fact that the non-trust fund programs have, in fact, had cumulatively spending of $14.3 trillion more than the revenue that they have taken in does mean that their total amount of $14.3 trillion has needed to be borrowed.
That's correct.
And it was perhaps a convenience that the trust funds were running excesses and could shoulder part of that burden.
Okay, thank you very much, and I yield back.
Mr. Tonko.
Thank you, Mr. Chair. Mr. Goss, I listened with interest to the exchange on the releasing of Social Security checks and find it rather amazing that we would even entertain the idea of allowing that to happen. And it really calls for us to build this consensus and respond appropriately. Given the barrage of calls for entitlement reform as negotiations on the debt ceiling continue, I'd like to take a moment to return to your testimony where you gave a very helpful explanation of how Social Security funds itself and what its impact on the deficit and debt are. We know the simple answer is that it has none. Social Security is self-funding and has not added one dime to the debt. However, in the face of repeated claims to the contrary and the policymaking that is now building upon those claims, I think this is an issue worth examining in greater detail. So could you please indicate for us the total dollar amount on assets in the OASDI trust fund, the Social Security trust fund, as you know it to be?
At the beginning of this year, the OASI and DI trust funds on a combined basis held about $2.6 trillion. We're right around that level, I think approaching $2.7 trillion.
Thank you. So Social Security has about $2.7 trillion in the bank. So, Mr. Goss, you pointed out that Social Security ran a cash deficit last year. That comes from discounting Social Security's interest income. However, given that Social Security has $2.7 trillion in what was until recently the safest investment bank in the world, the program is earning some pretty substantial interest. And if that interest income is included, Social Security income in 2010 totaled $781 billion, while outlays totaled $713 billion. Is that accurate?
I believe those are the correct numbers. Yes, the total interest credited to the trust funds in 2010 was in excess of $100 billion.
Thank you. So if Social Security was a business, it would have netted about just shy of $70 billion last year. Let me say that in a different way. If Social Security were a business, it would have earned well over twice the profits of the most profitable corporations in the world. It would have earned twice the profits of ExxonMobil, who raked in about $30 billion in profits. Despite having one of the most successful companies on earth, ExxonMobil gets government welfare and receives billions in oil subsidies approved by this body and defended by my Republican colleagues. It contributes more to our federal debt and deficit than Social Security ever has or under current law ever will. And yet our Republican colleagues are demanding entitlement reform and pushing forward bills to privatize Social Security and cut benefits while outright refusing to cut subsidies to big oil. That, I think, is rather interesting. Mr. Foster, an interesting point for me to examine is this line drawn in the sand by the Republican plan to end Medicare. At some point, you're 55 and you can't climb into the program. And the legacy population continues to age without a new population entering in. As I see the actuarial world, it's that younger population that doesn't consume as much health care that helps balance the pot and maintain the financial outcomes and stability of the insurance programs in this country, private sector or Medicare program. What's the impact of having this legacy population age without any new, younger seniors entering into the mix?
On the one hand, if you measure the average cost per person under current law versus the, as you deem it, the legacy population, obviously with a closed group of people who get older and older, a greater proportion of them die each year, et cetera, their costs per person are going to be much higher.
Right.
Now, the other way to think about it...
But what's the impact then on the program, on the finances of the program? There's no new group coming in from whom you're collecting premiums and perhaps using much less in healthcare and absorbing and costing more.
I'm not sure the impact is so different. In other words, either way, current law or this kind of proposal, for the 55 and over group, Medicare is still going to pay the lion's share of their costs.
Right, but premiums are held harmless.
That's right.
So what's the impact then? If you have no younger senior group coming in to absorb some of that ebb and flow, what's the impact of a growing, ever-increasing age group that...
Right. Well, that's the point I'm working towards, that for the older group, nothing really has changed. We're still paying them the same benefits. They're still paying the same premiums they would have.
But but who absorbs that cost, the added cost?
Well, so far there's no added cost.
The premium is constant. The group is growing older.
Well,
and you're saying that by per
same,
capita
the
they're paying more.
Current law, proposed law, they're the same people, the same cost. It hasn't gone up.
Thank you. Mr. Ginta.
Thank you, Mr. Chairman. Thank you both for being here. Mr. Foster, are you familiar with the Trustee of Trusts report that was issued back in May relative to bankruptcy of Medicare?
The Medicare Trustees report, yes.
Yes. What did that say? What if nothing is done, when does Medicare go bankrupt?
For trust fund financial status, you have to look at each account separately.
Okay.
The Part A trust fund is projected to have to run out of assets in 2024. The other two trust fund accounts are not projected to run out.
Okay, so 2024 is not that far off, about 12, 13 years. And what we have heard from our friends on the other side of the aisle in terms of solutions is either A, that is just false information and it's not accurate, which I disagree with. B, raise taxes either on beneficiaries or on other folks in order to pay for it. Or C, do nothing. And I say that because I have not seen a plan from the other side to preserve and protect Medicare. I think we have a responsibility in Congress to preserve and protect it. There have been proposals put forward, most recently passed by the House of Representatives, that preserve and protect Medicare. It doesn't affect anyone who's 55 or older. It recognizes and acknowledges that if nothing is done, Part A will go bankrupt in about 12 years. It recognizes that 10,000 baby boomers per day are coming onto the rolls, and that doctors each and every day, less and less doctors, are choosing to accept Medicare patients. So there is a fundamental problem in this country with the solvency, which Congress is charged with fixing. If we did it solely on raising the payroll tax, the tax is 2.9% today, correct? What would it have to go up to?
The tax is 2.9% split evenly between employers and employees. There's also an additional 0.9% for high-income workers. If you address the Part A long-range actuarial deficit just by raising taxes, then the tax rate would have to go up to 3.69%.
Okay, so,
Starting immediately. That's a 24% increase.
so starting immediately, you would have to go from 2.9 to 3.69.
Right?
This is on top of the Affordable Care Act increasing taxes $500 billion. This is on top of the President of the United States demanding tax hikes for some Americans that would exceed 50% of their income, 50% between federal, state, and local. This is on top of a 9.2% unemployment rate and abysmal 18,000 jobs created in June. That's 360 jobs per state in this country. Central High School in Manchester graduated 500 people this past month. There is a serious problem in this country that is not being dealt with by this Congress, by this President. And people in this country are frustrated with that. And what I think we need to be doing as members of Congress is not looking at raising taxes, but finding reasonable solutions to shore up Medicare, to shore up Social Security. Medicare right now, we spend in 2010, what, $520 billion roughly?
Yes, sir, that's correct.
What is your estimation that that number will increase to in the next 10 years?
Hang on just one moment. $932 billion projected for the year 2020.
So, not quite doubling, but we're in that neighborhood. And we have 47 million eligible Americans today. Do you have a projection of what that would go up to in 10 years?
Sure. We've got projections for just about everything. In 2020, 64 million.
64 million people. So from 47 to 64, but almost a doubling of the cost.
Yes.
These particular facts have to be acknowledged by Congress, and real solutions have to be proposed. The House of Representatives has put a proposal forward. Came out of this committee, passed the House. Nothing's been done in the Senate. Quite frankly, nothing's been offered on the other side. So I'd like to hear from the other side some solutions and some fact-based positive ideas rather than critique and criticism of the ideas that we continue to bring to the table. I yield back the balance of my time.
Well,
Ms. Bass.
before we hear from the other side, let me just say we would be very happy to help all of you on both sides in your efforts to find solutions.
You've been exceptionally helpful. We appreciate that. Ms. Bass.
Thank you, and I'd like to thank the witnesses for taking their time out to speak to us today, and also to my colleague, Mr. Inta. I don't want to mispronounce your name, I'm sorry. I do think that if you did want to know the ideas from the other side of the aisle, the Democrats did offer an alternative budget proposal and a balanced approach, which is something that I think that we could use, especially as we are getting very close, aside from the budget, talking about raising the debt ceiling, as we're getting dangerously close to jeopardizing our nation's credit standing. Wanted to ask you a couple of questions. Yesterday, and this question is for Mr. Foster. Yesterday, Secretary Sebelius said that Medicare is on a solid fiscal footing today because of the Affordable Care Act. And on page 6 of the 2011 Medicare trustee report, it says the financial outlook for the Medicare program is substantially improved, certainly not without concerns, but improved, as a result of the changes in the Affordable Care Act. So, Mr. Foster, I wanted to know, how would repealing the Affordable Care Act impact Medicare's financial situation?
There were, of course, very many savings provisions in the Affordable Care Act for Medicare. We estimated a total savings of $575 billion through 2019. If the law were repealed outright and retroactively, because some of these provisions have already taken effect, of course, then we would not have those savings.
Okay, thank you. And I also wanted to associate my comments with Mr. Tonko's, who left a little earlier, about the, I think we both heard the President's comments yesterday in response to the question of, if we didn't raise the debt ceiling, would we be able to make Social Security payments, as opposed to the President wanted to withhold those payments. I think when we do reach a balanced approach, we will be able to keep the Social Security payments on time. Mr. Gross, while my colleagues on the other side of the aisle claimed that the House-passed budget resolution did not cut Social Security, it does indeed cut the agency's funding by more than $10 billion over the next 10 years. And I realize that, you are the actuary, but I wanted to know your opinion, if you could describe what those size cuts would mean for the agency as it looks to serve, and we've certainly given numerous examples of the growing number of new retirees over the same period.
Very, very recently, in fact, my boss, Michael Astrew, Commissioner, testified before the Ways and Means Committee and indicated the necessity of maintaining sufficient administrative budget to be able to fully serve the American people. One of the charges that Social Security is working very, very hard at is to try to get the backlogs for Social Security disability applications down, especially as they are waiting for administrative law judge determinations. A reduction in administrative revenue for the program would, of course, make it much more difficult to do this.
Thank you very much. And I know that those of us on both sides of the aisle recognize that we do have to deal with our deficit and that cuts are needed, but I think this is an example that sometimes you can have cuts that actually create more problems for people than solving the situation that we're in now. Thank you very much for your time.
Plenty of time to spare.
You know what? I yield my time to the ranking member, Van Hollen.
Actually,
Well, let's just-
Chairman, if I could just say at the
Okay.
end, because I think it's been a very, very good hearing. Thank you, Ms. Bass. And I appreciate that windfall.
Yeah.
You don't get many on the Budget Committee windfalls. But let me just say I think this has, again, been a very important conversation. I just want to emphasize what I said at the past. And the Chairman has agreed we will have a hearing to look at the tax expenditures and revenue. And just a couple points in that regard. The median income of a Medicare beneficiary, median income, $22,500. The median income of a Social Security beneficiary, someone over 65, $25,000. Both those median income numbers include their Social Security benefit. My understanding is the average Social Security benefit is $14,000 a year. So when we talk about these issues, let's keep that in mind. And that's why it's so important from our perspective to have balance and also look at some of the revenue pictures and look at some of the folks who did get big tax breaks not that long ago. And again, during a time when the Clinton administration, we saw the economy booming and jobs created. Thank you, Mr. Chairman.
Gentlelady's time has expired. I will just simply say, when we do entitlement reform, we know there's limited resources. Those are the people who should get the most of the resources as we do this. Gentlemen, thank you very much for coming and taking your time. We really appreciate this. Hearing is adjourned.
Just remember, those are most of the people. But no, but